Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My dear students, today's topic is epistaxis. And epistaxis means bleeding from inside of the nose. Now this is a very important topic, not only for the patients but for the doctors as well, because everybody should know how to stop a bleeding from the nose. Now, blood that may come out from the nose can be trivial in amount, represented by just a streak of blood coming out of the nose, or it could be so much so that it could be rushing out and gushing out of the nasal cavity, and that is very scary. Now, you know, and everybody knows, that blood is life, and to stop it is our duty, because without blood there's no life. So when people see blood coming out of the nose of a patient, then usually their response is to rush at the patient and try to stop the bleeding. That is natural. But not every bleeding can be stopped like that by a normal person, by a layman. So one needs to know how and when to rush and when to go to a hospital to stop a nosebleed. Now, fear is an important element in any kind of bleed. It's more so in cases of a nosebleed. Well, people usually, a layman, he usually fears that the blood which is coming out of the nose is perhaps because of a brain hemorrhage, and that's what causes them to rush about and fear for the patient's life as well. Whereas if the patient himself or herself is a doctor, even then, if the blood is rushing out and gushing out of the nose, it can lead to fainting, it can lead to a lot of blood loss, and eventually a patient may go into shock. So it is very important to know what to do with a bleeding patient. And that's what this lecture is all about. Bismillahir Rahmanir Rahim. Today I'm going to talk about epistaxis. Now, epistaxis means bleeding from inside the nose. It can be mild in nature or become a life-threatening condition. Epistaxis is a symptom and a sign as well, but not a disease itself. Well, first of all, we talk about blood supply of the nose, since that is very important as far as the control of bleeding is concerned. So the nose is supplied, both the lateral wall as well as the medial wall of the nasal cavity, by two systems: external carotid system and internal carotid system. Now, the external carotid arteries that supply the nose are, the main one is the sphenopalatine artery, which is itself a branch of maxillary artery. It gives nasopalatine and posterior nasal septal branches. Septal branch of greater palatine artery, which is a branch of maxillary artery itself again, and septal branch of superior labial artery, which is a branch of facial artery. Now that is the external carotid system, whereas internal carotid system is by two arteries, anterior ethmoidal and posterior ethmoidal, which are branches of ophthalmic artery. Now, it's important to learn about little area in the nasal cavity as well, since most of the time the bleeding that comes from the nose comes from the little area. Now, where is it situated? It is situated in the anterior-inferior part of nasal septum, just above the vestibule. Four arteries, namely the anterior ethmoidal, septal branch of superior-labial, septal branch of sphenopalatine, and the greater palatine, anastomose here to form a vascular plexus called Kieselbeck's plexus. This area is exposed to the drying effect of inspiratory current and to fingernail trauma, and is the usual site for epistaxis in children and young adults. While retrocolumellar vein, this vein runs vertically downwards just behind the columella, crosses the floor of nose, and joins venous plexus on the lateral nasal wall. This is a common site of venous bleeding in young people. Well, this illustration shows the main arteries supplying the nasal cavity and mainly the nasal septum. What we can see is sphenopalatine artery giving its branches to the little's area of the nose where the Kieselbeck's plexus takes place. Anterior and posterior ethmoidal arteries also giving branches to the area, and greater palatine artery and superior-labial artery. They all form an anastomosis called Kieselbeck's plexus at the little's area of the nose. And little's area of the nose is about a centimeter internal to the vestibule of the nose on the septum on both sides. Now, what are the causes of epistaxis? What causes epistaxis? Well, we talk about local causes in the nose itself. And this, because the nose is vulnerable to trauma, because it's so exposed, trauma can occur to the nose itself, trauma can occur to the sinuses, trauma can occur to the nasopharynx as well. Whatever kind of trauma, whether it's accidental type of trauma or nail trauma, fingernail trauma, or a road traffic accident, or a fall, or some kind of surgery, they all can lead to an epistaxis. Whereas we talk about infections now, and infections can involve the nasal cavity in the form of acute infections like acute viral rhinitis, nasal diphtheria, acute sinusitis. They can all lead to epistaxis. Whereas chronic infections like all crust-forming diseases, for example, atrophic rhinitis, rhinitis sicca, tuberculosis, and other glomerular diseases. While chronic infections in the nasal cavity, sinuses, like all crust-forming diseases, atrophic rhinitis, rhinitis sicca, granulomatous diseases of the nose like tuberculosis, leprosy, syphilis, vagus granulomatosis, they all can cause an epistaxis. When we talk about foreign bodies in the nasal cavity, which can be living and non-living, living like maggots and leeches in the nasal cavity can give rise to bleeding, whereas non-living foreign bodies, for example, any neglected foreign body or a rhinolith, may cause bleeding from the nose. Now, neoplasms of nose and paranasal sinuses like benign tumors, hemangiomas, papillomas, and malignant tumors like carcinoma or sarcoma, they can all lead to bleeding from the nasal cavity. Atmospheric changes like high altitudes can give rise to bleeding, and sudden decompression can also cause tearing of the blood vessel and bleeding. Deviated nasal septum, especially when there is a spur vulnerable to trauma, it gives rise to epistaxis. While we were on neoplasms in the nasal cavity, we can talk about juvenile nasopharyngeal angiofibroma, which is a benign tumor occurring in the nasopharynx and coming towards the nasal cavity in the form of a polypoid mass and spreading towards the intracranial cavity, spreading towards the orbit, spreading towards the other areas. It can give rise to excessive bleeding from the nasal cavity in young adults, in males especially. Whereas inverted papilloma is another locally invasive tumor which can destroy the nasal cavity and give rise to bleeding. Squamous cell carcinoma in the nasal cavity again may form mulberry-like swellings or polypoidal swellings which bleed on touch. Adenocarcinoma in the nasal cavity is known to occur in furniture workers, whereas melanoma is a rare tumor, but it can occur in the nasal cavity. Neuroblastomas and lymphomas, they can all occur and cause bleeding from the nose. When we come to the nasopharynx, nasopharyngeal local causes can be due to adenoiditis or juvenile nasopharyngeal angiofibroma we just talked about, or malignant tumors like carcinoma of the nasopharynx. They can all lead to nasal bleeding. Now, talking about general causes of epistaxis, there are so many to talk about, like cardiovascular system problems, like hypertension, arteriosclerosis in old age. They can lead to bleeding, and profuse bleeding, mind you, and sometimes very difficult to control. Now, disorders of blood and blood vessels like hemophilia, von Willebrand's disease, Oscar-Randu-Weber syndrome, and so on. While liver diseases like hepatic cirrhosis can again disturb the coagulation and cause bleeding. Now, kidney diseases like chronic nephritis can also lead to epistaxis. Drugs, excessive use of salicylates and other analgesics, anticoagulant therapy, they can all lead to epistaxis. Mediastinal compression from tumors of mediastinum gives rise to raised venous pressure in the nasal cavity, in the neck and the nose. Now, acute general infections like smallpox and typhoid fever, mumps, measles, they can give rise to nasal bleeding too. Vicarious menstruation, which is epistaxis occurring at the time of menstruation. Now, they can give rise to bleeding from the nose. Now, systemic factors we just talked about are coagulopathies like thrombocytopenia, platelet dysfunction, systemic disease like uremia, drug-induced like Coumadin and non-steroidal anti-inflammatory drugs, and sometimes herbal supplements, while clotting factor deficiencies like hemophilia, von Willebrand's disease, hepatic failure, and hematologic malignancies, they can all lead to epistaxis. While these pictures show hereditary hemorrhagic telangiectasia, Osler-Randu-Weber syndrome, and sometimes hypertension among the systemic vascular factors and arteriosclerosis, they can give rise to epistaxis. Idiopathic. Having talked about so many causes of epistaxis, it's surprising to learn that many times the cause of epistaxis is not clear. About 80% of cases of epistaxis fall under this category, where we don't exactly know the cause of epistaxis. Now, sites of epistaxis, where the bleeding comes from, Little's area in about 90% of cases. Then above the level of middle turbinate, below the level of middle turbinate, posterior part of nasal cavity, diffuse both from septum and lateral nasal wall and the nasopharynx. These are the sites, and depending on the site of epistaxis, the blood vessels may differ. Like, for example, Little's area, it is the causal plexus where the bleeding comes from, and above the level of middle turbinate, it's usually the anterior and posterior ethmoidal blood vessels which bleed, while below the level of middle turbinate, it's usually the sphenopalatine artery and its branches which may bleed. Posterior part of nasal cavity has got a venous confluence, and that is called Woodruff's plexus, and that plexus is also notorious for a posterior bleeding from the nasal cavity. Now, diffuse can be from both the septum and the lateral nasal wall, and the nasopharyngeal bleed, say for example from nasopharyngeal angiofibroma. Now, classification of epistaxis can be anterior epistaxis and posterior epistaxis. In anterior epistaxis, the blood comes out from the anterior nares, and the bleeding point is fairly anterior in the nasal cavity. Whereas posterior epistaxis, usually bleeding occurs posteriorly from the nasal cavity, and the blood flows back into the throat, and patient may vomit coffee ground color vomitus. Differences between anterior and posterior epistaxis, one can just summarize it. Like, for instance, the incidence of anterior epistaxis is more common, whereas posterior epistaxis fortunately less common. Whereas the site of epistaxis, in anterior epistaxis, it's usually the Little's area or anterior part of lateral wall. Whereas posterior epistaxis, the site is usually posterior superior part of nasal cavity, which is difficult to localize as far as the bleeding point is concerned. Age, well, children and young adults usually have anterior kind of epistaxis, and the posterior epistaxis usually above 40 years of age. Now, cause of epistaxis, anterior epistaxis, it's usually trauma, whereas posterior epistaxis is spontaneous, often due to hypertension or arteriosclerosis. Bleeding in cases of anterior epistaxis is mild bleeding, can be controlled by local pressure or anterior nasal packing, whereas posterior epistaxis, the bleeding is severe and requires hospitalization and post-nasal pack in certain instances. When a case of epistaxis comes to us, and it's a severe case of epistaxis, then usually we have to investigate it, and investigate in the form of blood CP that tells us about the state of the blood, the platelet count. It tells us about the hemoglobin, whether it's low or normal, whether the patient's anemic or not. Then we can test the bleeding time and clotting time, just to learn about any bleeding deformities or problems, and then prothrombin time to learn about the liver state, and partial thromboplastin time just to learn about the coagulation process. Then we can do certain x-rays, like x-ray of the sinuses, x-ray of the nasopharynx, just to learn about any pathologies in that area. And geography sometimes, in certain cases where we suspect a bleeding tumor, such as a juvenile nasopharyngeal angiofibroma, and geography is very valuable. CT scan and MRI scan also sometimes done to tell about the site of epistaxis. Now, the management of epistaxis, in any case of epistaxis, it is important to know the mode of onset of epistaxis, whether it was due to trauma, for example, or due to certain infections occurring in the patient, or it was spontaneous or not. Then we have to talk about duration and frequency of bleeding. Then we have to know about the amount of blood lost, since we sometimes have to replace the blood lost, side of nose where bleeding is occurring from, then whether bleeding is of anterior or posterior type, and any known bleeding tendency in the patient or family. And we have to learn about history of known medical ailment such as hypertension, leukemias, mitral valve disease, cirrhosis, nephritis, etc. And history of drug intake like any salicylates, analgesics, anticoagulants, etc. Now, to summarize the management of epistaxis, it's 3. Arrest of hemorrhage is the first and foremost thing to do, since that is arrest of hemorrhage is part of ABC, which is airway, breathing and circulation manual, which is done in cases of emergencies. Arrest of hemorrhage is very important, since nobody likes to let the blood flow out and go to waste, because such blood is such an important and valuable thing to lose. Well, treatment of the cause. Next, after the arrest of hemorrhage, when the bleeding has been controlled in a particular patient, then we pay attention to treat the cause of that epistaxis in the form of, say, for example, treat the trauma, treat the infections, or treat any tumors causing epistaxis. Then supportive measures, which is in the form of rest to the patient and reassurance to the patient, and sometimes blood transfusions if a lot of blood has been lost, and so on. Now, talking about arrest of hemorrhage, the first and foremost thing is first aid. Since the bleeding from the nasal cavity of the nose does not see places, it may occur at home, it may occur at a school, in a child, it may occur on the road. So what one should do, and the doctor is not available all the time, so people must know what to do in cases of bleeding from the nose, especially if it's a child having a bleeding. So the parents must know what to do. And the first thing to do, if the child, say for example, starts to bleed from the nose, is pinching the nose with thumb and index finger for about 5 minutes. This compresses the vessels of the Little's area. In Trotter's method, patient is made to sit, leaning a little forward over a basin to spit any blood and breathe quietly from the mouth. Well, while cold compresses to the nose to cause reflex vasoconstriction is also in line. So that's the first aid. If that first aid does not control the bleeding, and the patient is at home or is in a school or is on the road, he has to go to a hospital to get examined. And when a doctor examines the patient and the patient is still actively bleeding, then the next thing for the doctor is to visualize the nose from inside and look for any bleeding points. If the bleeding point is visible inside the nasal cavity, the next thing for the doctor to do is cauterization. And cauterization is available in 2 forms. One is chemical cautery and the other is electrocautery. Now, in anterior epistaxis, when bleeding point has been located, one can cauterize the bleeder by using the first the area is anesthetized and the bleeding point is cauterized with a bead of silver nitrate or a chromic acid bead or coagulated with electrocautery. Here is a picture showing the first aid in case of nosebleed, how to squeeze the nose, how to pinch the nose. And the picture shows that the nose must be squeezed firmly above the nostrils, the softer part, and the head should be tilted a little forward so that any blood comes out of the mouth. It isn't swallowed. Now, nosebleed, make the patient sit down with his or her head over a sink or a bowl, pinch the sides of nose together, apply a cold pad to bridge of nose and wait. Instruct the victim to breathe through the mouth and not to sniff. If bleeding does not stop within 20 minutes, take the person to the hospital immediately. Now, this picture shows one is of chemical cautery and the other is electrocautery. Chemical cautery with a stick with a silver nitrate like a matchstick on the tip. This stick is touched on the bleeding point and that causes chemical cautery to that area, causing coagulation, necrosis of the mucosa, and later on fibrosis of the blood vessels. Now, this electrocautery picture shows a bleeding point in the lateral wall of the nasal cavity, and that bleeder is being touched with an electrocautery probe. Now, if the bleeding is not controlled by electrocautery or chemical cautery, or if the bleeding vessel is not visible, or if the bleeding point has not been localized, then the next step to control the bleeding or arrest of hemorrhage is anterior nasal packing. If bleeding is profuse and or the site of bleeding is difficult to localize, anterior packing should be done. Now, ribbon gauze soaked with liquid paraffin or BIP. Now, BIP, I told you earlier on in the anterior nasal packing BIP is bismuth iodoform paraffin paste. Now, about 1 meter gauze, 2.5 centimeter wide in adults and 12 millimeter in children, is required for each nasal cavity. First, few centimeters of gauze are folded upon itself and inserted along the floor, and then the whole nasal cavity is packed tightly by layering the gauze from floor to the root and layering the gauze from floor to the roof and from before backwards. One or both cavities may need to be packed. Usually it's both sides we pack. Then the pack is left in situ. Patient is usually hospitalized and the pack can be removed after 24 hours if bleeding has stopped. If it has to be kept for 2 to 3 days, then systemic antibiotics should be given to prevent sinus infection and toxic shock syndrome. Now, this is a picture of anterior nasal packing in situ. This has been packed. This nasal cavity has been sectioned sagittally and shows anterior nasal packing in situ. Now, if the anterior nasal packing we put has not controlled the bleeding, then the next step in the control of bleeding is posterior nasal packing. This is a special method of packing the nose, and for patients bleeding posteriorly into the throat, a postnasal pack is prepared by tying 3 silk ties to a piece of gauze rolled into the shape of a cone. Now, before we do a proper posterior nasal packing, it's better to try, first of all, Foley's catheter, which is easier to put inside the nasal cavity, and the balloon is usually having reached the nasopharynx, is inflated with 10 to 20 mL of air and left in situ. That may control a posterior bleeding with an anterior nasal packing. Whereas if that does not, a Foley's catheter does not control the bleeding, then one can try special nasal balloons that are also available with two balloons, one balloon in the nasal cavity itself inflated and the other balloon in the nasopharynx. Both balloons put pressure on the nasal mucosa and the nasopharyngeal mucosa, and a lot of times with these balloons, which are easier to insert, bleeding is controlled. Now if the bleeding cannot be controlled with these balloons, then one refers to proper posterior nasal packing, which is by means of a postnasal pack prepared by tying 3 silk ties to a piece of gauze rolled into the shape of a cone. Patient requiring postnasal pack should always be hospitalized. Now this shows the nasal balloons in the first picture and a Foley's catheter which is in place in the second picture. And this is the technique of putting a proper posterior nasal packing, which is by means of a gauze piece rolled into a Swiss roll like form with 3 usually silk ties. Some people tie 2 silk threads, one on either side of the roll of the gauze, and then 2 thin rubber catheters are inserted through the nasal cavities, one on each side, and those catheters, then the tips of those catheters are withdrawn through the mouth, and then the silk ties of the ribbon gauze roll are usually tied one each to the catheter, and then those catheters are withdrawn from the nose and they take in turn the silk threads with them, and the silk threads eventually withdrawn from the nasal cavity, and a finger then pushes the nasal roll of the gauze through the mouth into the postnasal space, and those threads, silk threads, are tied around the nostrils. Endoscopic cautery. Well, through a rigid endoscope, bleeding point is localized within the nasal cavity and cauterized under local or general anesthesia. This is endoscopic cautery. Now, elevation of mucoperichondrial flap and SMR operation can also be done in certain cases of epistaxis. Now, in case of persistent or recurrent bleeds from the septum, elevation of mucoperichondrial flap and then repositioning it helps to cause fibrosis and constrict blood vessels, while SMR operation to remove any septal spur is very helpful in certain cases. Well, if the bleeding cannot be controlled by all those previous measures, like for instance cautery, anterior and posterior nasal packing, and all that endoscopic cauterization methods, well, one has to resort to ligation of blood vessels. Now that is a slightly advanced procedure, and one can do it in one of the 3 forms. Either the external carotid artery is ligated in the neck, and that is ligation of external carotid artery above the origin of superior thyroid artery. Embolization or ligation of more peripheral branches can also be done. Now, maxillary artery ligation in uncontrollable posterior epistaxis, where endoscopic ligation of the maxillary artery can also be done through the nose. Then ethmoidal arteries in anterosuperior bleeding above the middle turbinate. The vessels are exposed in the medial wall of the orbit by an external ethmoid incision called the Lynch incision. Hereditary hemorrhagic telangiectasia is a disease that occurs in certain individuals and causes a lot of bleeding from the nose. Now, it occurs on the anterior part of nasal septum and it causes recurrent bleeding while it's treated by using argon or KTP or neodymium YAG laser. Now, if that is not possible, then one can resort to septodermoplasty operation, where anterior part of septal mucosa is excised and replaced by a split skin graft. Now, having controlled the bleeding, we have been talking about arrest of hemorrhage so far. Now we come to the general measures in epistaxis. Now what we do next, having controlled the bleeding, we make the patient sit up with the backrest and record any blood loss through spitting or vomiting. We reassure the patient and give mild sedation as well, because anxiety leads to bleeding. Keep check on pulse, blood pressure and respiration, while maintain hemodynamics. Measure the blood loss, and in certain cases blood transfusion should be done. Antibiotics to prevent sinusitis if PAC is to be kept beyond 24 hours. Now, intermittent oxygen should be given to patients with bilateral PECs. Now, one should investigate and treat the patient for any underlying local or general cause and treat the cause. That's the proper treatment of an epistaxis. Thank you very much.